Allaitement pour tous vous présente Frénotomie infantile, la précision du laser. Entretien exclusif avec le Docteur Martin Kaplan, pédodentiste et formateur des frénotomies au Tufts, école de dentisterie. Au mois de février 2015, je me suis rendue en Nouvelle-Angleterre, dans l'État de Massachusetts, où j'ai eu l'honneur d'observer le Docteur Martin Kaplan DMD dans son cabinet de dentisterie pédiatrique. C'est à cette occasion que je me suis rendu compte de l'importance de la formation lorsque j'ai pu observer et filmer 3 frénotomies les plus précises, efficaces, rapides et les moins traumatisantes du monde.
Hi, my name is Dr. Martin Kaplan. I'm a pediatric dentist in Stoughton, Massachusetts. I've been a pediatric dentist for 37 years. My initial dental training was at Tufts University School of Dental Medicine in 1972. From there, after I got my dental degree, I got a postgraduate certificate in pediatric dentistry at Montefiore Hospital and Medical Center in New York, which was a 2-year program as an intern. And since then, I've been in Stoughton, Massachusetts for the past 37 years treating my patients. 14 years ago, I was learning how to use lasers, and from that point on, here I am treating babies.
Avez-vous pratiqué des frénotomies infantiles au ciseau?
Never was trained in scissors frénotomies on infants. I had done surgical procedures on patients over the age of 4 or 5 with scalpels and sutures, but never on infants.
Combien pratiquez-vous de frénotomies par an en moyenne?
Now approximately about 1,000 plus a year.
Comment avez-vous pris conscience du lien entre les freins serrés et des problèmes d'allaitement?
Well, that goes along with the first questions about lasers. About 14 years ago, I was exposed to lasers in a lecture. I attended a laser class, and then I took an educational class with lasers. And from that point on, I realized the benefits of lasers. And this particular laser was a soft tissue or a skin removing laser, oral laser. And from that point on, I started to get some training, and I went forward with that. To be a little more detailed and maybe answer some other questions, after I took that preliminary course, I went to Tufts University School of Dental Medicine, where they were giving a standard certification class through what's called the Academy of Laser Dentistry, which is an international organization. And it's a 2-day class where I got training, got standard certified, and from that point in, I got to learn about all lasers related to dentistry, at least from that point in time. I joined the Academy of Laser Dentistry, and when I attended one of their meetings about 12 years ago, I started to learn about laser frénotomies for infants. And there was a particular lecturer there, Larry Kotlow, at the time, who was exposing us to the possibility of using lasers for infant frenectomies, which I never thought of before. So we asked if anybody was interested in learning or being referred some patients, because he had patients coming from all over the world to see him, which I kind of doubted at the time, but it turns out now I have people coming from all over the world to see me, which is pretty interesting that people have to travel outside their own country to get something done for their infant. But
so you get international clients.
I have clients this year that came from St. Croix, from Lucerne, Switzerland, from Italy, Spain, Israel, and someone from Paris this year alone.
St. Croix is
down in the Caribbean.
The Caribbean.
Caribbean.
It's an island in the Caribbean?
Yeah.
Comment les mamans vous trouvent, elles?
They found out about this through websites and Facebook pages on the internet, because there's a lot of Facebook pages where people communicate all over around the world, and there were certain people in the U.S. that are pretty well known to do procedures on infants, like Larry Kotlow, and there's an ENT surgeon in, I think it's Oregon, Bobby Gary, and a few other people that they may not be as well known, but a lot of people in the U.S. were trained, especially through the Academy of Laser Dentistry, and there's a phenomenal group of dentists that I know, and we're all very dedicated to treat the kids.
Quel est l'avantage du laser pour les frénotomies par rapport aux ciseaux?
I have no specific experience with scissors. However, with the scissors, you cannot be that specific with your cut. You have to be very delicate. You need to be careful about hitting blood vessels, muscles, nerves. The children can certainly be very wiggly, and if you don't have them stabilized well, as soon as you start to make an incision, if they flinch and the tongue comes out, you can poke them. And especially for the floor of the mouth, doing a tongue tie, I wouldn't feel comfortable doing that unless they were asleep. With the laser, you don't have that particular problem. And from what I do know from a lot of ENT surgeons that I've heard, and from a couple other oral surgeons that treat the procedure, they have a lot of difficulty with doing the scissors.
Donc, si l'on récapitule, cela revient à une question de précision, c'est ça?
It's precision, and also what I was trying to get to before. People usually diagnose and look at the obvious tongue tie with the teeth, or they call it either tethered or anterior tongue tie, because there are different types of ties. And they usually just snip the very front. But if you think of the tie is going from front to the back, or think of it like on a football or a soccer field, you have to go from one end of the goal to the other. They're only removing about half the tissue so that it's not fully released. There are certain times where, or many times I guess, where there's an improvement, but the benefit isn't always the best that you can get. And two reasons for that, I think, is they're not removing enough tissue. And also, when you do have a cut, you have a wound site. And unless you ask the parent to keep on stretching the tissue, which isn't a comfortable thing to do, to actually ask someone to re-tear open a cut 4 times a day for 2 weeks, you're going to get reattachment. And I have found over the past several years that some of the most difficult cases I have to retreat are kids that have, or babies that have had tongues that were actually scissored or scalpeled, and then they reattached, and it doesn't attach properly. As the tongue moves a little bit, there's scarring that goes on, and there's a lot of specificity you have to get with removing the tongue tie. It actually gets worse sometimes from the scissors.
Quels problèmes peuvent survenir à long terme si l'on ne traite pas un frein trop serré?
Well, two things. Depends on the frenum you're talking about. There's a lip frenum, and then there's a tongue frenum. For the tongue frenum, the kids often have coughing, choking, gagging. They swallow a lot of air for a lot of different reasons. There are many children that have diagnosis of gastric reflux or intolerance to the mother's milk, where essentially what it is they're just swallowing air that's mixing up with the mother's breast milk, especially for some of the newborn infants, because if I'm not mistaken, their belly's about this big on day of birth, and they have to nurse about 10 to 12 times a day. So if they're not swallowing well and they're swallowing a lot of air and milk, they're burping up and spitting up. And then also, since they're so short and their sphincters between their mouth and their anus is kind of loose, they're just burping, farting, and hiccuping. Another thing actually is the hiccups are significant because that is micro aspirations where milk is going down the back of the epiglottis, and the kids can have some significant respiratory distress from that. And as far as the lip goes, when the lip is tethered or tied, the lip is tight and they can't open up and flange well. And the babies are supposed to flange about 130 to 160 degrees so they can get enough attachment to the mother's breast. And if they're tight like that, they're slipping all the time and the mothers have a shallow latch. Along with that, the lip is pushing up against the children's nose. They have trouble breathing. They bob off and on because they can't coordinate their suck, swallowing, and breathing rhythm that is necessary for them.
Donc, pour tous ceux qui n'ont pas bénéficié d'une frénotomie à la naissance, c'est-à-dire depuis l'avènement de la naissance médicalisée, et qui vivent avec des freins serrés, quel est l'impact sur leur santé à l'âge adulte d'un frein serré non traité?
Well, I'm not a special in that particular field, but from what I know of in the 1930s when birth started going to the hospital instead of in the home, mothers were suggested to have bottle feeding and given formulas, so a lot of breastfeeding kind of fell out of fashion, and now it's coming back. So the skill sets for doing tongue and lip tie releases fell out of favor. There is a pediatric surgeon, I think her name was Dr. Corrales from New York, and she reintroduced this about 20-25 years ago, even though she was using the scissors, and she got tremendous results. And then other people that I know, there's particularly an oral surgeon who's a physician and an oral surgeon in New York City. He actually knew her and trained with her. And he does laser frenotomies like I do with the same type of specific laser, and we're all having good results. But there's also instances now where people have sleep apnea, snoring, head and neck disabilities, TMJ problems, and it turns out they've had a lot of problems because of tongue ties. There's gut issues too with reflux, and reflux people can't swallow, and just like the babies were spitting up and coughing, a lot of people have that issue too, or they're even gagging. I found in my own office there are a lot of children that have some gagging problems trying to take an x-ray. And when I ask about history, they had nursing problems when they were younger.
Comment avez-vous appris qu'il existe une telle demande de praticiens expérimentés en frénotomie pour nourrissants?
Well, it started out about 12 years ago when I was mentioning Larry Kotlow. He was suggesting that he couldn't treat the number of babies that he was seeing from around the country and the world, and I kind of was shocked that he would say around the world and the country, since sometimes it's hard to get patients to come from a few towns away to see you as a dentist. But I volunteered because I felt comfortable after 2 years of working with lasers with older children to be able to treat infants. And since I'm a pediatric dentist, I don't have any problems with seeing a newborn. So he started to refer me some patients. I saw about 2 or 3 a year. Then it started to build up as I became more confident. I also found that a lot of the lactation consultants in the area were thrilled to death that somebody was able to listen to them and understand the problems for the mothers, and it kind of snowballed where now I see approximately 500 babies a year.
Est-ce que vous recevez des bébés qui n'ont pas encore été vus par une consultante en lactation?
I prefer to have the mothers see a lactation consultant, but some don't have the availability of a lactation consultant, or the pediatricians may not have guided them in that particular position, or even their obstetrician gynecologist may not have suggested it, because many of the pediatricians and gynecologists don't believe that lip ties and tongue ties cause nursing problems, and it's mostly a problem with the mother or just a poor nurser. So I prefer to have the lactation consultants refer people to me, because at least there's a diagnosis of something potentially being wrong. Sometimes the problem can be corrected just with breastfeeding intervention. Sometimes there may be tongue ties or lip ties, and now they have a resource for us to work together.
Qui décide qu'un bébé a besoin d'une frénotomie ou non?
Well, I guess it goes back to training. A few years ago, as I started to get more involved, and I read more textbooks like Allison Hazel Baker, Catherine Jenner's, Marsha Walker, and Diana West, I learned more about diagnosis. And Allison has a tongue tie assessment that she uses for newborn infants. And I was at an International Association of Tongue Tie Professionals 2 years ago in Florida. And for 2 days, I didn't leave the classes because I got so much information about breastfeeding and assessment. And from there, I learned how to assess better posterior tongue ties, which are missed on a lot of kids, and even something called submucosal ties. So now I know what to look for, and it turns out there's a vast difference in the educational backgrounds of even the lactation consultants, even if they're an IBCLC, where they may have heard about tongue ties and lip ties, but they're not familiar with how to diagnose them. So I came up with a protocol to do an examination that's objective, along with the one Allison has and several other people have too, but I came up with me as a surgeon to be able to do one that I could train other people on how to do, or how to use. And so my assessment has to be for me to be able to see a tongue or a lip tie.
Comment avez-vous appris à évaluer la mobilité de la langue?
The conference and then experience in reading. Even though I was exposed at the conference, since then, as this pile of book shows, I've reread several of the books several more times, and I became more aware, and I'm very good friends with several of the lactation consultants, so we talk back and forth about different things, and we're actually helping each other.
Vous arrive-t-il de renvoyer des mères venues consulter pour une frénotomie?
Yeah, I do a total evaluation with the parents and the baby when they come in. They have to fill out a medical history first. I want to know a birthing history, whether there was a vaginal delivery or a C-section, depending on the birth. Sometimes it was difficult. The babies could have some neck or spinal cord strain, and then they don't really have a tongue tie. They just have a positional problem, which needs to be corrected. So depending on the birth history, the medical history, then I'll have the mother fill out her particular problems, where she has breast damage or whether she had mastitis, cellulitis, misshaped nipples. I need to know whether there's an anatomy problem, whether it's everted nipples, flat, or inverted nipples, because then the results that I'm going to expect are different. And then I also examine the babies to see what their suck is, what their tongue positioning is, how far they extend, lateralize, and cup. So I do a digital exam, a visual exam, and then I put 2 and 2 together and make a decision on whether I think it's warranted.
Pouvez-vous nous donner quelques-uns des critères qui indiquent un frein serré chez les bébés?
Well, for a lip, the babies cannot flange. They're usually very tight. They have no philtrum in the front. A lot of times their nostrils are widened and they seem like they have a broad nose because when their lip pushes up, they have some respiratory distress. And when they smile, there's actually no upper lip at all. And then as far as tightnesses for the tongue, I'll stroke my finger on the bottom part of the baby's lip to see if they can start to extend it, which is a natural reflex to about age 6 months for most of the kids. And I want to see if they can extend and keep the tongue out, if it blades or whether it cups or whether it becomes kind of blunted. Then there's tongue humping and dimpling. I'll put my finger on the jawbone and stroke back and forth, right and left, to see whether the tongue can follow me or if it's tethered and it can't move at all. And that's for the most part, it's it. But you'd have to watch me do an exam before things occur. Also, some of the kids cannot hold a pacifier. When I put my finger in, some of the kids will gag and choke and it doesn't go in far. Some of the kids will clamp down on my finger and I know they're chomping, so if they're chomping my finger, they have to be chomping on the mother's nipples and causing her problems. And then there's gas that a lot of the kids will have too, but that goes along with the assessment on the intake form versus the physical exam. And a lot of the kids are kind of colicky and they're crying a lot in distress. On the intake form, the mothers may tell me that they're nursing at will 24 hours a day. The babies are falling asleep at the breast. They have lip blisters, they can't open well, and their diapers can sometimes be dry. There's failure to thrive. I also have some children that don't have a weight problem. They actually are pretty heavy as far as weight goes, but that's because they're getting either supplement or they're getting the foremilk, which has a lot of calories in it, versus getting the full supplement of the after milk too. I don't know, there's just a lot of things to answer in a short time.
Donc, toutes ces informations, vous les obtenez grâce à la fiche de renseignement, l'examen de la mobilité linguale, l'observation de l'aspect de la bouche et les freins du bébé et de l'entretien.
Oh, I have to interview the mothers. But they come in, they have to fill out the forms. Before I even look at the baby, I'll review the forms, ask specific questions, which I think I gave to you before, so you can review those forms. I update them every 3 months because I come up with new ideas for things, but I want to keep it on one page. And the biggest thing is when we're doing any treatment or assessments at all, the mothers also have 24-hour contact with me because I give them my cell phone number, and if they have any questions, they can text me, or if they have a specific question and they don't know how to describe it, they can actually photograph off a cell phone and send me the picture by text message, and I can give them an answer.
Comme une infection, par exemple?
There shouldn't be any. I've never seen infection with a laser frénotomy. I've never heard of an infection anyways. Doesn't mean there couldn't be one because you can't have absolutes. Maybe someone had something dirty. I've had one case where someone was misdiagnosed with an infection, but what it was is the baby was crying, the mother was very stressed out, the pediatrician wasn't aware what the white mark under the tongue was afterwards, which is the white eschar. They thought it was an infection, and they put the baby on antibiotics, but nothing changed because it was just an eschar. Also, just while I'm thinking about that, there are a lot of times the children are misdiagnosed with oral thrush when it isn't thrush. It's essentially just dried milk on the back of the tongue that they can't clear off. And there are a lot of mothers and babies that are treated unnecessarily with thrush medication that they don't need.
Quel est le taux moyen de réattachement des freins chez les bébés que vous traitez avec le laser?
The children that I treat, I'd say it's less than 5%. It's very rare that I have any reattachment. I don't like the word reattachment. To me, reattachment is after you have an incision, you make a cut, you have two pieces that will seal back together. With the laser, if I can give an example, the web of my hand here is a certain size. If this was a frenum, the web would be up this side, and I'm essentially dissolving or ablating away that part of the tissue. And the only thing that could happen is it may fill up from the bottom as it heals, but it's not going to reattach. And having said that, some reattachment, I think it's a positional thing where the children may need a cranial psychotherapist or a baby chiropractor because their body is real tight and they're in a position where they're so tight that the tongue is being pulled back by the attachment to the hyoid bone, which is also involved in the strap muscles of the neck and also swallowing and the gut issues.
Faites-vous toujours à la fois une frénotomie de la lèvre et la langue, ou l'une des deux peut-elle suffire?
There's no hard and fast rule as far as doing both. I see about 90% of the time at least that a child has both. I also see the skewed population of infants because people that referred to me have a problem. They're not coming in for a routine examination. So all the infants that I see refer to them because they believe they have some type of a nursing or breastfeeding problem. So those particular children are already in a different category. So most of them are going to have something. I remember one particular case about 3 years ago where there was a baby that was referred to me. They were referred because Children's Hospital in Boston said if their baby didn't gain 4 ounces in the next 2 weeks, they were going to put a feeding tube in because they thought that failure to thrive was pretty significant. I saw the baby on day 9 of 14. I only saw a lip tie, did a lip tie release, and within the next 5 days, the baby gained 3.5 ounces. The mother went to Children's. They told them they still wanted to put a feeding tube in. The mother refused. She was she was threatened with child neglect, but the mother still refused to do the treatment to put the feeding tube in. She came back a week later. The baby gained another pound, and then the hospital just said it was just dumb luck that everything worked out right, but the baby did not need a feeding tube. I'm sure there are cases where feeding tubes are necessary, but in this particular case, there was something obvious that needed to be done. It wasn't attended to, and the baby was having failure to thrive. I think he even was on reflux medication of Zantac or Prevacid because the baby was spitting up and not keeping any of the fluids in. But this case turned out was just lip tie only.
Quel modèle de laser utilisez-vous?
Currently, I use a carbon dioxide laser. There are several lasers in dentistry that you can use. One's an ND-YAG, one is an erbium, one is a carbon dioxide, and another one is a diode laser. I initially started out using diode lasers, have no problem at all with them, and there are various numbers that go along with them from 810 to 1064 to 900s. That part doesn't matter, except that the diode lasers are essentially a fine glass tip that can remove tissue. There's an ND-YAG that you can use too, but I have found that even though I don't use it, people have used it. That puts out a lot more heat and energy, and some of the attachment problems that some of the children have is because they're using a laser that's too powerful and the training is inadequate. So you could probably use any instrument. If you know the skill set and know the limitations of your laser, then you can do a job adequate for the tool you have. I tried the carbon dioxide laser recently only because I was able to create a training class at New England Medical Center in Boston at Tufts to help train other dentists and physicians how to use lasers to diagnose and treat children with tongue and lip ties. And I heard that ENT surgeons usually use carbon dioxide lasers. So on a fluke, I met a carbon dioxide laser company at the Academy of Laser Dentistry. They offered to have me try it. I tried it, loved it, and it's the only laser that I'll use now. I do have the other ones as backup. I have no problem with anybody using any type of laser as long as they're trained well. But the carbon dioxide laser for the physics of tissues actually penetrates the least amount, has the least amount of what you call collateral damage. But if you don't use your tool well, the laser well, it doesn't matter how good the laser is. If your skill set isn't good, you're going to have a problem. The other thing too is not everybody heals the same. Not all parents will do the home care afterwards. You have to be able to stretch, do tongue exercises. Ideally, you want to work with a lactation consultant. In cases, you probably need a craniosacral therapist or a baby chiropractor to get a good team approach. It's kind of difficult nowadays where everybody's so busy and the insurance coverages are different, and there's a lot of controversy, which I think is unnecessary between all the physicians, dentists, and other paraprofessionals. But I think that kind of answers everything.
Pouvez-vous citer quelques avantages du laser que vous utilisez actuellement par rapport à celui que vous avez utilisé dans le passé?
Yeah, that's pretty easy. The laser that I'm using now will remove tissue. It's almost like taking an eraser and removing some pencil off of a paper. I can remove about a 20th of a millimeter of tissue at a time erasing it, versus the other laser has a significant amount of heat on it, and you're taking away a lot more than that. So I can almost put my laser on a piece of paper with ink on it, touch the laser to the ink will disappear, it'll be white on the other side. Having said that, you do have to cool your tissue in case there's some extra heat that's going on. There's electrosurgery that some people use too. I have no objections to anybody using whatever means they have as long as you're using it the right way. Skill sets aren't all the same, but that's why I also think training is indicated. because just because something is there, if you're unfamiliar with what you're doing, you need to be able to have some training. And training helps. There's different types of severities of tongue ties and lip ties, and you also have to know the medical history of the baby, whether they have a cardiac problem or not. I have a few babies that had some cardiac disease without too many anomalies. However, their heart rate is faster, their metabolic rate is faster, they breathe faster, and if they have a nursing problem, then that gives them more of a problem because their oxygen consumption is being used and wasted by on nursing inappropriately. So these kids actually get healthier because their body isn't strained as much.
Donc, lorsque des praticiens sont formés à l'Académie de dentisterie au laser, à l'utilisation de ces types spéciaux de laser, est-ce qu'ils sont aussi formés à faire des frénotomies sur les bébés?
No, they're trained to use the laser.
Okay.
So you're trained in a skill set, but then it depends if you're comfortable doing that. Just like some general dentists will see somebody only after teenagers, and general dentists may not want to see children. I have no problem seeing newborns all the way up to special needs adults who are 86 years of age. So it depends on comfort level. So not everybody's comfortable treating an infant. They'd rather let it go to somebody else, just like there's a pediatrician or a family practitioner or a general dentist or a pediatric dentist.
Okay.
Alors, on sait qu'ils ont des compétences pour utiliser le laser au moins, dans la mesure où ils ont été formés à utiliser le laser pour des tissus mous.
They were trained. As far as
Trained,
how
yeah.
good they are, then that varies.
Okay.
But that's why I wanted the class at Tufts, because this way we have a lactation consultant, we have a laser certified instructor, and myself, giving 7 hours just specifically of infant training classes only. Ideally, we want to make it for 2 days to get other professionals in, like chiropractors, craniosacral, feeding specialists, and speech pathologists in. But this is the first time ever, as far as I know, in the world that this class is being done. So we have to start small before I go big.
Je vois que vous avez saisi l'intérêt et l'importance de combiner les compétences pour traiter les sujets.
Oh, absolutely. And myself and a few other people are always fighting against, I guess, a wave of naysayers. There are I can't say everybody, but there are a significant number of pediatricians and ENT surgeons who don't believe that this exists. And all I can say is if a mother has breast and nipple pain, the baby's not growing, at least look in them out to see if something else is going on. Just because you can give somebody a bottle doesn't mean they're going to feed better. And just because there are reflux medications or other medications to give somebody doesn't mean you're taking care of the problem. You're just using a Band-Aid. And while I think about it, there was a 4-month-old baby who I saw recently that was referred to me that was in the hospital with an IV for dehydration, had 2 bladder ultrasounds, 2 kidney ultrasounds, and had 2 catheterizations of his ureter because they couldn't figure out what was wrong. All he had was a lip and a tongue tie that was released, and 4 days afterwards, after we did the treatment, gained 4 ounces.
Est-ce que les ORL pratiquent des frénotomies sur les bébés ici aux États-Unis?
I don't know what their training is, but from what I do know, there's a reluctance to do tongue tie frenotomies, and lip ties, it's pretty rare that they want to do it. They usually defer it to the dentist. And when there is a significant tongue tie, most of the ENT surgeons will suggest that the mother wait until the baby's about a year old to go into general anesthesia and do a major Z-plasty. Out of the thousands of treatments that I've done, I've never seen anything significant enough to warrant that. And literally, when I use a laser, the carbon dioxide one takes me about 5 to 7 seconds to do a release. The diode laser may take me a few seconds more, but that's all it does. There's no general anesthesia. There's no medications they have to give the baby. It's really quick. It's no more uncomfortable than doing a heel stick for a blood test or an immunization. And it's definitely kinder than putting a feeding tube in and seeing what's going on or starting an IV.
Traitez-vous des adultes souffrant des freins serrés?
I have several people that I've seen in my practice that didn't realize they had a tight frenulum. They had problems with snoring. They had problems with sports where they were fatigued easily. There are even some of my children that have Crohn's disease, have gastric reflux that we recognized had tongue tie issues. We've released them, and many of the symptoms just immediately went away. It's almost like a miracle pill.
Même dans le cas de maladie de Crohn?
The Crohn's disease, this person also had bad reflux, and the tongue was held down, so they had problems with the Crohn's in the reflux, and the shoulders are up high all the time. So once we released that, she was so happy. She actually gave me a hug, but I didn't mind because I've known her for 20 years, since she was 3. the Crohn's disease wasn't treated, but her upper airway issues and the shoulder pain and neck pain were taken care of. So she had that on top of her Crohn's, which is an uncomfortable disease to have anyways.
Est-ce que la frénotomie a eu un impact positif sur la maladie de Crohn?
I'm not sure if it made it, well, actually, yes, it did. It made it less severe because the reflux started to go away. She didn't have the negative pressure build up when she was swallowing, so she didn't have the irritation in her stomach as much, and her Crohn's has actually been much more controlled.
Pensez-vous que le taux des freins serrés chez les bébés a augmenté depuis les années 80, lorsque les sages-femmes ont cessé de les traiter à la naissance, ou pensez-vous que c'est juste parce qu'on en est plus conscient aujourd'hui?
I actually can say I have no idea. The only thing I know is that the more people are trained, it seems like more people are recognizing and diagnosing problems. So I think it's a matter of being familiar with the issues versus ignoring it before. Your head was in the sand, you didn't realize anything was there. I myself can blame myself, 12 or 13 years ago, I didn't realize what was going on, and now I wish I knew more than that. But every single day that we treat a baby and, we get the improvement that we see and the mother's happy, it's just very rewarding to be able to help these people.
Comment les praticiens peuvent-ils se former pour faire de bonnes frénotomies?
Two things. Number one, you need laser training, and I think to do that you have to go to an academy. So the Academy of Laser Dentistry gives you the basics of training for lasers. They teach you laser physics, the type of lasers, biotype, meaning the type of tissue that's there, whether it's thin or thick or bloody or fibrous. You'll know how to decide which laser works best in your hands, how to sterilize it, the proper laser protocol for safety, for eye protection. People that are in the vicinity have to be protected too. And I think once you learn how to use a laser, then you need a class specific for the type of surgery you're doing instead of general certification. And that's where I think this class at Tufts is very important. I don't know why it's the first in the country, but it's a class where we're going to just specifically rely on this. If people weren't trained in lasers, they're going to get a lot of education, and then we're strongly suggesting before they use a laser that they get certifications so they have the good basics to understand what they're doing. Just buying a laser from a company or having a salesman sell you a laser, give you a setting like it's a cookbook, is not a good reason to just start using lasers. You need to be trained.
Thank you very much.
You're welcome.